Hello everyone, I'm Dr. Surbhi and we'll be discussing diabetes insipidus today. Diabetes insipidus is characterized by a high plasma osmolality and a low urine osmolality. By definition, it is characterized by passage of large volumes of dilute urine, that is, more than 3 liters per 24 hours of dilute urine, which is less than 300 milliosmoles per kg in osmolarity. Diabetes insipidus is of two types. One is central and one is nephrogenic. Central DI is characterized by a deficiency of ADH, that is antidiuretic hormone, while nephrogenic diabetes insipidus is characterized by insensitivity of the kidneys to ADH. We'll discuss the causes of central as well as nephrogenic diabetes insipidus. Central diabetes insipidus is more commonly idiopathic. It can also occur following head injury or a pituitary surgery. It can occur following tumors like craniopharyngioma, can occur in histiocytosis X. It can also occur in Wolfram syndrome, which is characterized by diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. So, Wolfram syndrome is also associated with central diabetes insipidus. The causes of nephrogenic diabetes insipidus include most commonly the genetic forms. There are two forms of genetic or congenital nephrogenic diabetes insipidus. One is characterized by vasopressin mutation, that is vasopressin 2 receptor mutation. It is the most common form. It is X-linked and because it is X-linked, it affects only the male members of the society. The other form is the aquaporin 2 mutation. Aquaporin 2 mutation is the less common form. It is also autosomal recessive and it leads to decreased water absorption in the distal tubules of the kidney. So, among the two genetic forms of nephrogenic diabetes insipidus, the vasopressin 2 mutation, which is X-linked, is more common and affects only males. Aquaporin 2 mutation affects the water absorption in the distal tubule of the kidney, is the less common form and is autosomal recessive. Other causes of nephrogenic diabetes insipidus include electrolyte imbalances like hypercalcemia and hypokalemia. Hypokalemia, it causes desensitization of renal tubules to ADH. The desensitization of renal tubules to ADH causes increased water excretion. Other causes of nephrogenic diabetes insipidus include drugs. Drugs, which are the commonest precipitant drugs causing nephrogenic DI are tetracycline or demiclocycline and lithium. Lithium inhibits the signaling pathways that involve glycogen synthase kinase 3 beta type signaling pathways, which are inhibited by lithium are, again repeating, glycogen synthase kinase type 3 beta. It leads to the dysfunction of aquaporin 2 water channels in the distal tubules, leading to nephrogenic diabetes insipidus. So, I'll again repeat the statement. Lithium, it inhibits the signaling pathways glycogen synthase kinase 3 beta, which leads to a dysfunction of the aquaporin 2 channels in the distal tubules, leading to nephrogenic diabetes insipidus. Fourth form of which can cause nephrogenic diabetes is the tubulointerstitial diseases like obstruction, the distal part, sickle cell traits, and pyelonephritis, causing nephrogenic DI. Now we'll discuss the clinical features of nephrogenic diabetes and central diabetes insipidus. Both have same features of polyuria and polydipsia. Polyuria in diabetes insipidus, polyuria occurs, that is when urine output is more than 50 ml per kg per day. Diabetes insipidus is suspected when urine output is more than 50 ml per kg per day or there is presence of nocturia. In absence of nocturia, remember, diabetes insipidus is very unlikely. So, polyuria is present, urine output more than 50 ml per kg per day or presence of nocturia. There is also presence of polydipsia, that is increased thirst. Next, we'll discuss the investigations. Remember, in suspected diabetes insipidus, the most appropriate investigation is the urine and plasma osmolality. Diabetes insipidus is characterized by a high plasma osmolality of more than 295 milliosmoles per kg, and urine osmolality is low, which is less than 300 milliosmoles per kg. Remember, with a high plasma osmolality, there is increase in the serum sodium to more than 145 milliequivalents per liter, and with urine osmolality is decreased in the urine sodium to around 20 to 60 millimoles per liter, and urine specific gravity is also decreased. Urine specific gravity is also decreased to less than 1.005. This is very characteristic of diabetes insipidus. If a diagnosis is not made by the plasma and urine osmolality, we can next do the water deprivation test. So, discussing in detail the water deprivation test, it is a test that is used to confirm the diagnosis of diabetes insipidus. In this, we ask the patient not to drink water for around 8 hours. The patient is deprived of water or fluids for around 8 hours or until 5% of the body weight is lost. Now, after 8 hours of deprivation of body fluids, we ask the patient to empty his or her bladder. Then the patient's urine and plasma osmolality are measured every 2 hours. Now, if without administration of desmopressin only by water deprivation, the plasma osmolality it is increased, while urine osmolality also increased above 600 milliosmoles per kg without desmopressin, remember, then a diagnosis of primary polydipsia is made and central and as well as nephrogenic diabetes insipidus are ruled out. But if the urine osmolality still remains unchanged, that is still less than 600, then we proceed further with desmopressin administration. So, as discussed in this diagram, we do the water deprivation test with 8 hours of water deprivation. If without desmopressin, the urine osmolality reaches more than 600 milliosmoles, a diagnosis of primary polydipsia is made. While if the plasma osmolality is increased, but the urine osmolality is no change or it remains less than 600 milliosmoles per kg after water deprivation, then we proceed further for desmopressin administration, that is DDAVP administration. So, after desmopressin administration, if the urine output it increases more than 600 milliosmoles per kg, then a diagnosis of central diabetes insipidus is made. While even after desmopressin administration, if the urine osmolality it remains low, then it is confirmatory for the diagnosis of nephrogenic diabetes insipidus. So, how we'll differentiate primary polydipsia from diabetes insipidus, central as well as nephrogenic? In primary polydipsia, after the water deprivation test, after the water deprivation of 8 hours or fluid deprivation of 8 hours, without desmopressin administration, the urine osmolality falls. It increases to more than 600 milliosmoles per liter per kg. However, in central and diabetes, the central diabetes insipidus and nephrogenic diabetes insipidus, the urine osmolality does not change after water deprivation alone. After desmopressin administration, however, if the urine osmolality it increases more than 600 milliosmoles per kg, then it confirms the diagnosis of central diabetes insipidus. If the urine osmolality still remains low even after desmopressin administration, then it confirms the diagnosis of nephrogenic diabetes insipidus. In primary polydipsia, the lab findings will be a hyponatremia. Plasma osmolality will be low to normal, while urine osmolality will be very low. While in diabetes insipidus, central as well as nephrogenic, there will be mild hypernatremia, that is increase in serum sodium. Plasma osmolality will be increased to normal, while the urine osmolality will be low. So next, coming to the management of central as well as nephrogenic diabetes insipidus is being discussed here. So the central diabetes insipidus, the drug of choice is desmopressin. So desmopressin is a synthetic vasopressin that does not have any effect on blood vessels. That is, it does not have any vasoconstrictive effects. Side effects of desmopressin includes hyponatremia. In central diabetes insipidus, desmopressin is given along with an increase in the oral water intake. However, if desmopressin is ineffective, we can also give synthetic ADH intranasally or intravenously as well. Now, the management of nephrogenic diabetes insipidus, it can be divided into two groups. The congenital nephrogenic diabetes, that is genetic, that is caused by either vasopressin 2 receptor mutation or aquaporin 2 mutation. So the drug of choice in congenital diabetes insipidus is sildenafil. Sildenafil is a phosphodiesterase inhibitor that has been shown to substantially reduce the urine output in patients with congenital, especially the X-linked one, that is the vasopressin 2 receptor mutation. Other point to note here is that congenital nephrogenic diabetes insipidus is generally unresponsive to exogenous ADH administration. Point to note is congenital nephrogenic diabetes insipidus is generally unresponsive to exogenous ADH administration. Next group is the lithium-induced nephrogenic diabetes insipidus. It will respond to cessation of lithium. We can also restore body volume if in presence of hypovolemic hypernatremia with 0.9% saline. Once euvolemic, we can shift over to 0.45% saline, but preferably we do not give saline anymore. We use 5% dextrose, or we can also use free fluids. If the cessation of lithium is ineffective in improving the condition, we can give thiazide diuretics. Thiazide diuretics, amiloride especially, can be given. Amiloride, it blocks the epithelial sodium channels in the cortical collecting duct where lithium enters and causes the diabetes insipidus. So thiazide diuretic, amiloride, it blocks the epithelial sodium channels which are present in the cortical collecting duct where lithium enters. We can also give NSAIDs like indomethacin in cases of nephrogenic diabetes insipidus. So this concludes the management of diabetes insipidus and the topic as whole. Thank you.